Assalamu alaikum, everyone.
Walaikum salam, ma'am. Walaikum salam.
Okay, so let's begin today's session, inshallah. Okay, as I said yesterday on the group, that we are going to divide glioblastomas into different sessions because it was quite a long topic and I wasn't sure if I could do justice to it in 30 minutes. So today we are going to cover the core glioblastoma. And in the session on Sunday, we might have two sessions on Sunday, one covering the surgical nuances and one covering the treatment strategy and what is new in the glioblastoma. So let's begin. And we might have a slightly different format today. I would share the imaging first and then the case later. So take a very good look at this image and what do you think this makes you think of? What is the first thing that came to your mind?
Glioblastoma, ma'am.
Why?
Sorry, oligodendroglioma. Oligodendroglioma.
Madam, high grade lesion.
Okay, just comment on the radiology. So, would anybody volunteer to comment on the radiology without telling the diagnosis directly?
Can I try?
Yeah,
Ma'am,
sure.
the slice.
Ji,
This
Dr.
is the
Mustafa.
axial cut, T2 weighted image. This is
Okay.
the axial of the brain, T2 weighted image showing the 5 into 5 centimeter space occupying lesion at the right frontal lobe, which causes the subfalcine herniation and perilesional edema. And this is the heterogeneously contrast enhancing lesion.
Okay. And how does it look? Is it well circumscribed? Is it poorly circumscribed? Do you see a CSF cleft sign? What do you think?
Well circumscribed lesion.
Okay. And do you see a CSF cleft sign here?
It is a well circumscribed. CSF, ma'am.
CSF cleft sign. Do you think this is extraaxial or intraaxial?
This is a extra axial.
Oh, why do you think this is extraaxial?
Hello. Can you
Yeah.
listen, ma'am?
Yeah, I can. Your voice is clear. Dr. Mustafa, your voice is perfectly clear.
No, sorry, ma'am. Sorry, it is intraaxial lesion. Right.
Why do you think so?
Because it is invading the parenchyma.
No, when we are
Seems
talking
like.
about radiology, we need to justify the radiological findings. You cannot see whether this is invading the parenchyma or not. That would be a histopathological diagnosis, if I am not wrong. So on on the radiological features, what are the things that are suggestive that this is intraaxial or extraaxial lesion?
Sorry, ma'am.
Okay, would anybody else volunteer, please?
Okay, can I try?
Yeah, sure.
Okay, so this is a MRI, axial cut MRI. I go from the left to right. On the left is a T2 sequence. On the right is T1, and on in the middle is T1. On the extreme right is a T1 post contrast. So on the left, I can see a large globoid lesion, well-defined borders. It is heterogeneous in appearance. It's compressing lateral ventricle with there is a mild subfalcine herniation. There is also perilesional edema. On the middle, there is a iso-intense lesion. Iso-intense lesion. And on the extreme right, the lesion is contrast enhancing. It is heterogeneous in the nature. There is features of central necrosis. So I think this is an intraaxial lesion. It is not an extraaxial lesion because I don't see a broad-based dura. There is no CSF cleft sign on the T2. There is no obvious cortical buckling. And ideally, I should see on the bone window for hyperostosis. I do not see that feature over here. So therefore, my provisional diagnosis, given the fact that it's um, a heterogeneous lesion and intraparenchyma, I would be thinking of a high-grade lesion. It's possible it's a high-grade glioma. In this case, maybe a glioblastoma. That is my provisional. My other possible differentials, a it could be a METS, a metastatic lesion. Yeah, that would be my
Dr.
provisional and differential.
Nilishambigai,
Yeah.
a very warm welcome from Pakistan. She is from Malaysia. And
Thank you.
that was a very good presentation. But I have two questions for you since you were really amazing with radiology. There are only two questions. What do you think of the attachment here at Fox? One. And the other thing, what do you think of this cleft sign here? Because there is CSF cleft sign. If you can see my cursor, is my cursor visible?
Yeah, it is.
Yeah. So what do you think of these two things? It's a very
Um,
well circumscribed lesion, and
yeah.
heterogeneous enhancement is also a feature of high-grade meningiomas. We can see
Okay.
the false sign attachment here. We can also see a very small dural tail, maybe, and the CSF cleft sign here. So, do you still think and can you still defend your diagnosis of glioblastoma or an intra-axial lesion per se?
Mm, so if I yeah, I do see that. Now that you mentioned, doctor, I do see that the CSF, but it is not that very visible. I mean, I would expect it to be
It's not
larger.
completely a classic appearance of CSF cleft sign, but there is some remnant here. Okay, so
Mm,
let's move to the case presentation.
okay.
So this was a 56 years old woman who presented with progressive headaches and a new focal weakness. MRI brain shows a well-defined dural-based frontal convexity mass with a homogeneous, mostly contrast enhancement and an apparent dural tail. There is significant surrounding edema, but the lesion itself looks extra-axial with preserved cortical margins. So do you think of anything that mimics meningioma on imaging? There are two or three very close differentials.
It could be a hemangiopericytoma, a solitary fibrous tumor, or a
Yeah,
dural mets.
yeah. Among those, hemangioperitocytoma would be a much closer differential. And there is one more thing that we will come later to uh, in this presentation. So, what do you think of this? Can anybody else volunteer? No volunteers? We have quite a few participants.
Uh, uh, I'm Dr. Sanaslim. Can I do, ma'am?
Yeah, sure. Assalamu alaikum.
Welcome, salam, madam. Madam, picture number A is a T2 MRI brain axial cut showing a lesion on the left side of the temporal lobe that is mixed intensity lesion, and it is showing a CSF cleft sign on the on interiorly of the lesion, and it, on B the is the contrast image of the same lesion that is heterogeneously contrast enhancing, that is shows a central intense lesion and the surrounding is hyper intense, and the C is the coronal section of the same image that is also contrast in with contrast and is heterogeneously contrast enhancing. Yes, madam.
Yeah, so what is your first impression? What is this? What could be this? Because radiology is often misleading.
Ma'am, it could be a high grade lesion. Um, uh, yes, ma'am, high grade lesion.
Do you see a
Um,
dural tail here? The yellow arrow?
yes, madam. This is dural
And
tail.
do you see small CSF cleft signs around here?
Yes, yes, madam.
So what would be your first impression?
Mm, yes, uh, uh, madam, dual differentials is discussed hemangiopericytoma and solitary fibrous tumor and the meningioma, atypically a high-grade meningioma.
Okay, somebody in the chat box has written gliosarcoma. Who is that? I would love to hear from you. Okay, maybe they don't want to. So, yes, there is another differential, which is gliosarcoma. And let's solve these cases later on. I want to keep the suspense alive today. So, for this case, this was a 57 years old woman who presented with headache, ataxia, and memory lapses for the past month. Brain MRI demonstrated a large heterogeneous enhancing right temporoparietal mass with broad contact along the right tentorium. Along with minimal vesogenic edema, CSF cleft sign, and dural tail sign, final radiology interpretation noted findings most suggestive for a meningioma. So, this patient underwent embolization of middle meningeal artery, leading to decreased tumor blush. And when the patient was operated, it was a necrotic tumor, which is not a surprise since post-embolization tumors get necrotic often. And the final pathology revealed a diagnosis of glioblastoma. Why that happened, we are going to see. So this is another case. What do you think of this? This is a post-surgical image, a CT brain, plain, and showing a resection cavity. Would anybody like to comment? What is going on here? It's probably the easiest one of those three. No volunteers? Okay, so
Madam.
what happened here is this was the original operative site, right? We all can appreciate that there is a bone flap here, there is a resection cavity, and here is the reactionary fluid. And what happens next is in a few hours or days, maybe, there is another hemorrhage here. And this site is this is farther along from the original resection cavity. So, can somebody comment why this happened and what this is? It's the most common, not exactly most common, but the most expected, most dreaded complication of glioblastoma surgery. I'm
This is glioma syndrome.
This is wounded glioma syndrome, right? And who answered? I'm sorry, I didn't see your name.
I did.
Oh, where are you from?
I'm from Nigeria.
That's amazing. We are very, very happy to have you here with us. Yes, this is wounded glioma syndrome. And why do you think a hemorrhage happens far away from the original surgical site where we did not intervene? Do you have any idea about the mechanism?
Not clearly explained, but in wounded glioma syndrome, there is release of some inflammatory cytokines and other inflammatory markers from the tumor that was probably subtotally removed. So that can trigger hemorrhage in a remote site from the site of the surgery. That's one of the pathogenesis. Though the explanation is not clearly demonstrated, but this is a preposition of what could result in wounded glioma syndrome.
Okay, we are going to discuss at least one possible mechanisms of wounded glioma syndrome because yes, there isn't a very clearly defined pathogenesis, but we do have some ideas. So, following subtotal resection of a frontal GBM, a patient worsens within hours. Imaging shows new hemorrhage edema not only at the resection cavity but also in a separate tumor focus remote from the surgical site. How do you explain the mechanism? And usually, what we see in wounded gliomas is extensive hemorrhage and edema at the site of surgery, not farther along. So, we are going to comment on that as well. Let's begin the course section. Glioblastomas are IDH wild type. We have already established the glioma classification in the first session. They are IDH wild type, they are WHO grade 4, and we either need histologic grade 4 features, which are necrosis and microvascular proliferation, or even if the grade 4 histology is not present, if any of these mutations is present, it is a grade 4 tumor. We need TERT promoter mutation, we need EGFR amplification, and whole chromosome 7 gain, whole chromosome 10 loss. So, what do you think is happening here? Does anybody has any idea about subventricular zones and what are those? What is their link with glioblastomas? Okay, so take a look. The cell of origin of glioblastomas is a neural precursor cell which is present in the subventricular zone. Subventricular zone is a small region which lies adjacent to the lateral walls of the lateral ventricles. And this is an area which is rich in stem cells, the precursor cells, and these are the regions which harbor the tumor cells and they act like cradles, they act like safe havens. Penetration of chemotherapeutic agents is very low here, so it sort of becomes the primary reservoir. Subventricular zone is recognized as both cradle and haven for glioblastomas, and it serves as both the site of origin and a reservoir that protects the cancer stem cells from the standard treatments. So, we already know this, that glioblastomas are the most common adult malignant primary brain tumors. Peak incidence is between 55 to 85 years of age. This is mostly a disease of older age, but we do have some exceptions when we come to the subtypes. And if most of you would recall, it was called glioblastoma multiforme a few years ago. It was called that particular name because it does have a lot of shapes and forms and subtypes and sometimes even age distributions. This is a chart from the Greenberg, and this establishes the diagnostic criteria. This is a diffusely infiltrating astrocytic glioma. It needs to be IDH wild type and S3 wild type both. We somehow forget the S3 wild type. All we remember is that this is IDH wild type. But technically, for the molecular definition, we need both of these. And any of these features, one or more. Microvascular proliferation, necrosis, TERT promoter mutation, EGFR gene amplification, plus 7 minus 10 chromosome copy number alterations. So, are you all with me till here? Should I move forward?
Yes.
ये
Yes.
+7 या -10 का क्या मतलब होगा मैम?
Plus 7 का मतलब है we are gaining a chromosome 7. We are gaining an extra chromosome. And here this chromosome is deleted.
Thank you
think,
ma'am. Thank you.
okay. Okay. So, wounded glioma syndrome occurs due to acute disruption of the tumor microenvironment. What happens is when we take out the tumor, tumors, especially high-grade tumors, they are very rich in the vascular supply. There is a lot of neovascularization, microvascular proliferation, and these are new vessels. New vessels means these are baby vessels, and they are very unstable. Their lining is also very unstable. So what happens is they are very sensitive to pressures, to any changes in ICP, and when we take out the tumors, there are two other things that happen as well. Angiogenic factors, they escape in the bloodstream along with inflammatory mediators which also escape. And this leads to hemorrhage at the site. The reason for for the bleed at tumor foci which were away from the main resection cavity is because these are hidden microscopic tumor foci. They are not visible with the naked eye or even on the imaging, early imaging. What happens is there is early development of tumor foci here, and the new vessels that are being formed, they are still very fragile baby vessels, and they are also very sensitive to the pressure. So once we do the surgery here, it leads to a cytokine storm, sort of, and that ends up having a hemorrhage at a distant site as well. So I think we did see quite a few interesting cases in the beginning of this session, but let's discuss the typical imaging first and then the atypical imaging. So the classic appearance is, we all know, it's irregular ring enhancement. Usually the ring is thick, irregular, and there usually is central necrosis, which is non-enhancing, hypointensive core on T1 weighted images. It does not show diffusion restriction. There is vasogenic edema, extensive T2 flare hyperintensity. So these are the typical imaging features that we all are used to see in our patients. You can see the irregular ring enhancement here and the central non-enhancing core, which signifies the necrosis. You can see the same thing here. This is butterfly glioma, which is a very typical appearance of glioblastoma. What happens is the genu of corpus callosum is involved here because this is interior. If this would have been posterior GBM, then the splenium would have been the pathway. So this ends up spreading towards the opposite hemisphere as well. So this is the typical imaging, right? I think I don't want need to go over it in detail. What do you think is happening here?
The lesion
Okay.
has spread across the corpus callosum, the splenium of the corpus callosum.
Exactly. It's the butterfly glioma, but it's the type of butterfly glioma that we don't see pretty often. So what happens when the splenium gets involved? Because this patient is not going to come to you with very typical presentation.
So they'll have a disconnection syndrome, left and right dissociation. And the prognosis is rather poor for this.
Exactly. They have disconnection syndrome. Apart from disconnection syndrome, they also have a visuospatial disorientation because splenium is the region which connects the visual areas and the spatial areas. So the patient is very disoriented. It also plays some role in the awareness and maintaining the consciousness. So patient might have altered level of consciousness. Patient might be disoriented. So these patients are going to present with very atypical features. So here's a prettier picture. And this is a butterfly glioma. Unfortunately, a handshake tumor. I read a few years ago in a book that GBM is called a handshake tumor because you can't do anything but offer a handshake to the patient. So this is the typical appearance of a GBM on MRS. It is characterized by a high choline peak and a decreased N-acetylacetate peak. This is a very typical picture, and it helps us in ruling out when the imaging is deceptive. So the subtypes, which is what misled all of you in the beginning. Giant cell glioblastomas, we have three main subtypes: giant cell glioblastomas, epithelioid glioblastomas, and there is one more, gliosarcomas. Yeah. So giant cell glioblastomas are rare IDH wild type GBM. They have a propensity to occur in younger patients than the classic GBM. Younger means 40, 50, the group 10 years younger than the classic GBM group, which starts from 50, 55 plus something. And they arise de novo. There is no known precursor. And these specific subtype tumors have 75 to 90% TP53 mutation and PTEN mutations. So gliosarcoma, which is a mimic for meningiomas, and these are IDH wild type GBM variants. They are not as common, 2 to 8%. They are biphasic tumors, which means they have both the glial components and the mesenchymal or sarcomatous components. And they may arise de novo without any precursor lesion, or they may arise after a GBM was treated and then they recurred, sort of. They can also appear in conjunction with ependymoma and would be called ependymosarcoma. They can also appear in conjunction with oligodendroglioma, which will be called oligosarcoma. So, if the tumor is predominantly sarcomatous and not glial, then it is going to mimic meningioma radiologically. The images that you all saw in the beginning, they were not meningiomas. They were very close mimics of meningiomas, though they were gliosarcomas. Epithelioid glioblastomas, these are the variant in the younger age group, young adults and children, and they also have a predilection for cerebellum and diencephalon. There is a very high rate of BRAF V600E mutations, and I think there is a role of uh, BRAF inhibitors, but I am not very clear about it, so let's not go there. And they are very aggressive. They are more aggressive than the classic GBM. So this is a very quick overview of the radiology of epithelioid glioblastomas. If you see, these are also a very good mimic of extraaxial lesions. They are broad-based, they look extraaxial, very well circumscribed. When we look at them, GBM is not the first thing that comes to our mind. So I think all through these sessions, I have reiterated again and again that radiology is a very good tool towards identifying any particular condition, but it can also be very misleading, and therefore we should not completely depend on it. So let's conclude our session for today. And before I escape, is there any constructive damage that you would like to do? I am completely open to any feedback. The next session includes gliomas, multiple gliomas, intra-op adjuncts, standard treatment algorithm, the prognosis, and surgical nuances. I'm not sure if we would cover it in one complete session or it would be broken in two sessions, but all of these will be happening on Sunday, inshallah. So, any feedback? Any questions?
Hello, thank you, ma.
Okay.
Can you hear me?
Yeah, I can.
Okay, I'm Dr. Ken Obiagu from Nigeria. So,
Oh,
thank you for your efforts so far, ma. So, I would like to ask, first of all, you mentioned that glioblastomas could also be known as handshake tumors. Please, can you expand on that?
oh yes, it's a very informal term. We offer handshake that when we cannot offer the patient anything else, as in GBM, even with all the recent advancements, it is still not a tumor that leaves a lot of life to live. You are practically handling a death sentence when you are telling a patient that they have GBM. So, in a very informal capacity, it has been called a handshake tumor because all you do is a handshake and say that you're very sorry that this has happened to them.
Okay, thank you very much. Then secondly, considering the fact that radiology could be very misleading, as you rightly said, with the advancements in radioionics, does that still hold water? Could radioionics help us to pinpoint or specifically cone down our diagnosis?
Oh, yes, I have been reading about radiology, and I think radiology is going to be one of the first fields that is going to be very heavily infested and infiltrated by AI. And I think it's going to end up improving the accuracy. And yes, I think it would lead to a far more accurate picture before the surgery. It's ultimately going to end up being better for the patient.
Okay, then lastly, if you don't mind,
Yeah, sure.
there's there's subventricular layer
Yeah,
where glioblastomas act as cradles and heavens.
yeah,
Why
yeah.
is it difficult Why is it difficult for antibiotics to reach there? Why?
I am not 100% sure. I can read up on it and get back to you with a more detailed explanation. All I have read so far is the drugs have a higher level of resistance in penetrating this region. Why? I'm not sure, but I can definitely get back to you on Sunday if you're going to join us again.
All right. Thank you very much, ma'am. I'm grateful.
Okay. So let's end the session. Have a good day, everybody. Allah Hafiz.
Thank you, Doctor. Good evening. Bye.
Thank you.
Thank you. Allah Hafiz.